Hey, good morning, everybody. We are going to get started. Glad to see you all here. I want to introduce Dr. Fagelson. He is going to give a talk this morning here with the Department of Audiology, Speech Language Pathology. His undergraduate and master's from Columbia, and PhD at University of Texas at Austin. I think we're all really looking forward to the talk. Really appreciate him being here. So without further ado, I'll hand it over.
Thank you, sir. Appreciate that. My name's Mark Fagelson. I'm mainly over at ETSU. I also run a tinnitus clinic at the VA that I started in 2001. We've got about 1,000 patients or so enrolled in that. There's this, and there's this. Are we okay now? Right? They can't agree on much, but they can agree that I don't speak for them. So we'll perhaps leave it at that. What I'd like to talk about today are some relations between primary psychiatric disorders, psychotropic meds, and tinnitus. And what I'm going to try to pitch to you today, what I'm going to try to sell you on today is the idea that tinnitus, which we all kind of recognize as some kind of buzzing, hissing, tone-like sound that we all hear once in a while in bursts for 20, 30 seconds, or maybe even more consistently than that. I'm going to try to sell you on the idea that tinnitus is not just an auditory disorder, but it's also a psychological disorder in the sense that it can provoke in people very powerful psychological responses, so much so that it would actually, such responses would actually influence a person's quality of life in a substantive way. And I think once we kind of look at tinnitus that way, then interventions become a lot more sort of intuitive in some ways, but not unintuitive in other ways, because, again, most people are kind of stuck on the idea that it is an ear disorder. So my first job today is to make sure that you understand it's not solely an ear disorder. And then we'll talk about different mechanisms and different behaviors that kind of highlight the links between tinnitus and psychological state. Now, because, first of all, everybody in here knows what tinnitus is. Everybody's heard tinnitus from time to time, right? Actually, just about everybody will hear bursts of tinnitus for, like I said, up to about a minute or two, maybe, idiosyncratically. Just seems to come out of nowhere and then goes away. We actually call that normal tinnitus because so many people experience it. And the idea is you're convinced you're hearing a sound because the part of your brain, the primary auditory cortex, in which sound is processed, is activated in individuals with tinnitus, even though there's no activation in the ear itself. So we've got a true sensory event as far as the brain is concerned that is entirely uncorrelated with what's going on in the environment. So you can imagine how that can have an influence on somebody's psychological state. So we do recognize that the brain is active in tinnitus, the primary auditory cortex in particular, but we also know that if somebody has very bothersome tinnitus, maybe unilaterally with normal hearing in the other ear, and they decide to seek a surgical intervention that might include sectioning the eighth nerve. In 2/3 of those cases, the tinnitus either stays the same or gets worse, even though the patient is now deaf on the side of the head where the surgery was performed. So we're pretty confident that there's a substantial central nervous system component to tinnitus, and that's what I, again, want to try to highlight for you today. We know that some individuals with bothersome tinnitus will rate their tinnitus as very loud, very high-pitched in different kinds of ways. But what we really want to be recognizing, is that, sorry about that, is that for the most part, this ear source theory, an otocentric theory of tinnitus, by now is refuted through a variety of different experiments. We do know that in some cases, inner ear disease can cause tinnitus, but that's much rarer than what we normally think of as the kind of subjective tinnitus that bothers other people. And if we want to make a nice distinction in that case with regard to intervention, we would recognize that we want to distinguish treatment from management, where a tinnitus treatment technically would be an intervention whose purpose is to change the tinnitus sound itself, ideally abolishing that sound, compared to a management strategy which would target the patient's response to the tinnitus, their psychological response to the tinnitus, and try to modify that while not worrying about what the sound is. I think we all know, just from listening to sound, and I'll go into this in more detail later, different sounds affect us in different ways, and some sounds that we find very appealing may be very disturbing to other people. And that has a lot, of course, to do with the experience that that the individuals bring to the listening task. So we want to keep that in mind as well. I did want to point out here, though, that there are a few things that have been used for tinnitus that have also been used for depression. Interventions for tinnitus that have also been shown to be therapeutic and beneficial for a variety of psychological disorders. So again, we want to recognize that there are these links between the two, and we're going to see shared mechanisms, and we're going to see shared treatment approaches or management approaches for both tinnitus and psychological conditions. Let's very quickly distinguish between subjective and objective tinnitus. Objective tinnitus would be tinnitus that's actually audible to an outside observer. So on occasion, we'll get a patient at the VA who will tell us they hear something like this, right? And on occasion, it's actually been happening to the patient while they're in the clinic with us, and I work with a lot of students, and in that case, I will very quickly grab a hearing aid stethoscope and put it into the patient's ear canal, and you can actually hear the objective tinnitus being made by that patient's ear. And that's something that students, I think, get a lot out of experiencing. So there are a variety of causes for that. We also know that AVMs in the head and neck region can be responsible for turbulent blood flow, and that can also produce audible sensations. What we really want to worry about with respect to objective tinnitus would be those cases where the tinnitus is described by the patient as pulsatile, whooshing sometimes. But what we need to determine, what we need to determine is how to use this device. What we need to determine is whether that pulsing or whooshing sensation is in any way time-locked with the heart rate. And if a patient complains of something like this and you ask them, well, does it speed up when you run up the stairs or when you exert yourself? If the answer is yes, that really requires immediate medical attention. And so those are questions that are worth asking, especially in cases of pulsatile tinnitus. So that, among the objective tinnituses, tinniti, we'd say that the pulsatile is the one most meriting medical attention. By far, more commonly, we're dealing with patients who have subjective tinnitus, which would be the conscious experience of a sound uncorrelated with any environmental source. These, as we'll see in a few moments, are this kind of tinnitus affects probably close to 1 billion people around the world. Not amenable to surgical or medical intervention. And so what we really want to focus on then will be the effects on the patient, and of course we'll have to interview the patient to get a better handle on that, so that we can target whatever intervention we're going to employ to deal specifically with those problems. Another thing to keep in mind is that tinnitus is very often associated with hearing loss. It may be tinnitus that brings the patient into the clinic, but once their hearing is tested, it turns out they also have hearing loss. Let's manage the hearing loss first. In a lot of cases, managing that hearing loss actually ameliorates a lot of the distress produced by the tinnitus. In terms of prevalence, in terms of the numbers of patients in the U.S. and worldwide who have tinnitus, we recognize that it's probably somewhere in here for the U.S., worldwide, The vast majority of the people, that would be the blue part here, the vast majority of the patients are not bothered by their tinnitus at all. So if you get those bursts of tinnitus that I just described, and that's all you get, and you don't think about it very much, you'd probably be in there, okay? We also know, however, that there are millions of people who are very bothered by their tinnitus. They may not be debilitated by it, but they're very bothered by it. It keeps them awake at night, a few nights a week, for example. It stresses them out once in a while. They can still function, but for the most part, the tinnitus is a minor, more or less a minor annoyance. However, there are also millions of people, and this is just in the US, with tinnitus that has profoundly reduced their quality of life, profoundly affected the way that they go through their day-to-day existence. And so those are, of course, going to be the folks we really need to be thinking about. Several large-scale epidemiological studies have indicated some risk factors, and I think a lot of these risk factors would also be associated with various kinds of trauma, psychological or physical as well. There are a lot of medications associated with the development of tinnitus, and there are some other compounds that are associated either with an exacerbation of a pre-existing tinnitus or an amelioration of tinnitus. And whoops, and again, some of the recreational drugs, for example, might even fall into both categories for some individuals. This is from the VA's annual benefits report. I just wanted to point out here the odds ratios associated with a variety of mental health diagnoses. And the idea here is that we wouldn't necessarily think that a mental health diagnosis would be associated with hearing loss, for example. We do see slight increases with respect to hearing loss in the odds, but with tinnitus it's generally higher than it would have been just for hearing loss in isolation. That's true for all of these groups except for the PTSD group, and I'm sorry they kind of got cut off over there. And that's kind of ironic because we've done a lot of work with patients who have PTSD, and I'll talk about this later, where they're actually much more bothered by their tinnitus than patients who do not have PTSD. So this one, it kind of stands out a little bit, but you see the trend for most of these is that the odds ratio of tinnitus being reported increases in the presence of a mental health diagnosis. If we need a little bit more evidence that tinnitus is not solely an ear problem, we can compare degree of hearing loss to self-assessments of tinnitus severity. So here's an individual from the VA who's got a pretty standard high-frequency sloping sensory neural hearing loss, nothing particularly not much of a big deal with respect to this hearing loss being very unusual or anything. And what we're going to do is we're going to ask this patient a bunch of questions about their tinnitus. These, I don't know if you can read these are questions along the lines of, because of your tinnitus, is it difficult for you to concentrate? Does it make you anxious? Does it make you feel depressed? Do you feel as though you cannot escape it? Is it influencing your quality of life? Those kinds of questions. And so this person with this hearing loss answers these questions in this way, thereby revealing a very severe, self-assessed tinnitus handicap. Let's take another patient whose hearing is actually worse than the first one we looked at, and this person evaluates the impact of the tinnitus in a completely different way. So we can't really say that hearing loss and tinnitus are well correlated at all. There are people with perfectly normal hearing audiometrically who have disabling tinnitus. There are people who are profoundly deaf who do not hear tinnitus at all. There are people who are profoundly deaf and all they hear is tinnitus. And of course, there are people with normal hearing who are not bothered by it at all. And so if we now compare, and this would be in a population of patients who have either tinnitus alone or tinnitus with post-traumatic stress disorder, we can see that their pure tone averages, their auditory sensitivity is for the most part not different across the groups, but their ratings of the tinnitus severity, in other words, their self-assessment of the handicap produced by the tinnitus, indicates that that group with PTSD assesses their handicap as more severe than that experienced by the group who did not also have post-traumatic stress disorders. So this overlay of a psychological disorder onto tinnitus seems to influence the tinnitus. And interestingly, if you look at the trauma literature, patients, for example, with PTSD who also have tinnitus will rate their PTSD as more severe than those patients who have PTSD without tinnitus. So there seems to be a pretty powerful mutual reinforcement that we want to be able to at least understand or recognize. It's also interesting to ask these patients with either PTSD or some other kind of mental health diagnosis to rate either the loudness of the tinnitus, its intrusiveness, their ability to tolerate moderately loud sounds, or even their hearing loss. Now, when we looked at this figure here, there's no difference between the groups with respect to their sensitivity. Yet here, what we see is those same individuals are rating their hearing loss as much worse than the patients who did not have PTSD as a diagnosis. So clearly something is happening with these patients where they are somehow mislabeling or misinterpreting what's going on either with respect to their own sensitivity or the tinnitus or other sensory events that makes it so that their own assessment, their assessment of their own ability to function is influenced by whatever it is that seems to also be making them miscalculate, for example, how bad their hearing is, or miscalculate how loud sounds are in the environment. When tinnitus gets started in an individual, we typically associate it with some kind of change to the way the auditory system functions. That could be related to hearing loss caused by hair cell loss, but it can also be associated with changes occurring centrally. And the idea might be, or the one that we kind of work with, is the idea that peripheral damage will be compensated for by central mechanisms. And clearly that's not something that is limited only to the auditory pathway. But given that possibility, then it might be reasonable to say that if we can control that neuronal excitability centrally, we might be able to modify that tinnitus perception. So the goal here with respect to targeting the tinnitus pharmacologically would be to modify the activity in the CNS, and in doing so, modify the tinnitus sound itself. The fact that I'm up here talking to you should provide you all the information you need to know that that's not happened yet. And I would argue that we're probably nowhere close to having a drug that on its own would be able to substantially modify tinnitus in enough people so that that drug would outperform placebo. And I think that the reason that we'll look at why that's going to occur, but the main thing to keep in mind is that tinnitus can be caused by a lot of different things. And just as we're saying that the disruption produced by the tinnitus is going to rely on the person's psychological response to that sound, you know how different everybody can be and how different their experiences are. So it's going to be very difficult to find a drug that's able to address that galaxy of problems that so many different patients bring in. One thing I like to remind patients of, because a lot of the folks that I see at the VA are convinced that the sound exposures that they endured are solely responsible for their tinnitus and solely responsible for the problems caused by the tinnitus. And so it's always worth reminding people that tinnitus has been in the medical literature since at least the 8th century BC, since at least Babylonian. There were no loud sounds back then, volcanoes maybe. So we recognize that tinnitus is, in a sense, part of the human condition. It's been with us in one form or another for a very long time. We also know from some slightly more contemporary writings that tinnitus also very often goes along with what's known as decreased sound tolerance, or that hyperacusis I was mentioning a little bit earlier. It's kind of paradoxical. Individuals with hearing loss will very often complain that everyday, routinely experienced sounds are too loud for them. You wouldn't expect that, yet that's what many of them will report. And that fits in nicely with our story of central compensation for peripheral damage, because if that central compensation is taking some kind of form of either amplification or disinhibition, then sounds that used to be comfortable for the individual may now be uncomfortably loud because the auditory pathways activity has changed. We also recognize that here in the 1800s, Itard, who was a French otolaryngologist, kind of gave up trying to eradicate the sound in his patients and settled instead on presenting other sounds to those patients to try to mask out the sound of the tinnitus. In a sense, substituting one sound for another. Why would that work? Well, if a person doesn't have the psychological association with the new sound that they have with the old sound, then that new sound might interfere with whatever process has been bothering the patient with respect to the tinnitus. So masking seems to work pretty well for a lot of people, even though you could make the argument that all you're doing is swapping one sound for another. It's what that person thinks about the sound that dictates how it will affect them. And I think that's maybe doesn't even need to be said. It's a pretty obvious idea. We also, as I mentioned before, are going to have to be aware that psychological comorbidities are going to make things a lot more difficult for our patients with tinnitus. So to kind of summarize very quickly maybe where tinnitus comes from, let's recognize that there will be some change, perhaps some damage in the auditory periphery, hair cell loss, nerve damage, any number of things. Those changes may even be subclinical. In other words, there can be damage to the inner ear. The more anxious a person rates themselves being, the more likely they are to rate their tinnitus as more handicapping. And we also know that the rates of these disorders in our tinnitus populations tend to be pretty high. A quick word about PTSD, because that's the patient group that I kind of have migrated toward over the years. I think a prevalence rate of 35% of patients having PTSD, that's kind of high out of any patient group you could imagine, I think. And that's what we've seen in our clinic at the VA. More than a third of the patients that we see for tinnitus end up also having a diagnosis of post-traumatic stress disorder. I first sort of found that after I had recognized that I had a subgroup of patients that were much more disturbed than any patients I was seeing reported in any studies or during any talks that I went to. And when I went into CPRS at the VA and looked at all those charts, the one thing that I kept seeing over and over again in these patients was post-traumatic stress disorder. So it really does seem to be something that interacts in a very powerful way with tinnitus. These are some of the problems that these individuals will talk about. The patients with post-traumatic stress disorder who have tinnitus can very often even tell you the moment they first heard their tinnitus. It was when they woke up on the side of the road after they'd driven over that IED. Now, you want to recognize that that individual may have memory associated with tinnitus onset that places them on the side of the road in the dust so that when they hear their tinnitus or when it becomes bothersome, perhaps they have memories of that event triggered. So you can see how the potential is there anyway for some very powerful mutually reinforcing events to occur. Reactive tinnitus means tinnitus that gets louder when you hear some other sound. So these are, again, individuals who will hear a car door slam, they'll jump, and they'll notice that for the next half an hour their tinnitus is louder than it was before the car door slammed. Those kinds of differences, again, highlight the need to focus a lot of attention on this population. What we end up recognizing is that it's very possible for some patients to have a hard time accurately evaluating the environment around them. They will tend to misinterpret sensory events. And you know that individuals with depression, with anxiety do that often. Individuals with PTSD do it often as well. Sounds can create levels of arousal that are consistent with survival type responses, even when they're not called for. For example, let's take a look first at one kind of schema that was put forward by Schnur and Janikowski at the White River Junction VA up in Vermont, where they include in this PTSD circuit of effects this idea, man, I'm really sorry about that, this idea that individuals are going to perhaps mislabel sensory events to which they are exposed. They will have exaggerated startle responses. We've seen plenty of that. But I would also suggest they're going to have a difficult time labeling their tinnitus accurately. So let's very quickly just take a look at what happens when we hear a sound, at least on a very surface level. We recognize that when we hear a sound, especially if it's a sound we're not really familiar with, we have to establish its priority. We have to establish how important that sound is going to be. We have to analyze it. And usually when we do that, we use not only our ears, but we use our eyes. We find out what's making that sound, and we're able to, in hopefully a quick and accurate way, determine what we need to do in response to that sound. But that measurement that we make will be influenced by our experience. It'll be influenced by the conditions under which we first heard that sound. It will be influenced by whether the sound triggers any positive or negative emotions. So here's one way to think about it. There can be some kind of external event. There will be neural activity following that. There will be some processing that occurs. And what we'll see is that different parts of the auditory pathway and different emotional elements will actually be brought into the analysis of this event. And if the sound is evaluated accurately and some response planned, then there will be the potential for changes in autonomic activity, even in other mechanisms. But what we really want is to know whether we need all this kind of reinforcement and all that feedback to sharpen our response and to create a more active response. So let's see what happens when this is done accurately. The door slams, the sound is processed, the sound is identified, right? Maybe you saw a door slam. Maybe that sound is familiar enough to you as a door slamming so that when it occurs, even though you kind of get startled and jump for just a moment, you recognize it's a neutral sound. Your emotional state does not change at all. There will be no required change in any kind of alerting or arousal system because the sound is benign. There will be no feedback. The response will be muted. But if the processing of the sound is inaccurate, and again, this seems to happen more, at least in our experience, with patients who have post-traumatic stress disorder and some other mental health conditions, the door slams, it's processed, but it is identified differently. Maybe the sound of that door slamming as an unexpected impulse sound was reminiscent of an explosion or some other component of a traumatic event in the past, in which case the sound now may be judged in a completely different way and will recruit neural mechanisms that didn't need to be recruited in the analysis and response to that sound. And so the feedback system remains active and in place, amplifying whatever response was generated. The story that we hear from a lot of our patients is, patients with PTSD would be something like this. Friend comes up from behind the patient, gives the patient a good whack on the back to say hi. Patient turns around and takes a swing at their friend, because that entire event was miscalculated. That entire sensory event was misinterpreted, and the response disproportionate to the stimulus. So that's the kind of thing that we're talking about here. This misinterpretation of sound can produce these exaggerated responses to sounds that really should have been rated as innocuous. The vast majority of the patients that we see, more than 95% of them, have tinnitus that is not a symptom of anything they need to worry about. It's more a symptom of changes that have occurred in the central pathway in response to damage in the inner ear. Yet patients are very often convinced that the tinnitus is an important indicator of impending deafness, exacerbation of mental health disorder, any number of things. It might even be linked to memories that the patient really does not want to have. So in those cases, yeah, the responses to the tinnitus, as well as the responses to other sensory events, can be exaggerated to the point that they are now unignorable. They cannot be habituated to. We also want to recognize that this kind of thing, especially if it produces that abnormal sensation of loudness for everyday type sounds, can really produce in the patient a great need to avoid stuff. And we know that especially with any kind of central changes, avoidance is only going to make that situation worse because you'll never be able to get desensitized to the sounds that are bothering you. So that's yet another problem. So with respect to auditory and psychological responses to tinnitus instead of just to sound, we've got a few things that are still similar, but we want to recognize that tinnitus really is a classic psychosomatic condition in the sense that a person's response to it can actually change the way day to day they're able to live their lives. If you're not sleeping well, your life is going to be affected. If you're feeling stressed out all the time, that's going to influence the way you go through your life. We attribute a lot of this problem, a lot of the misunderstanding of what tinnitus is on the part of the patient, to the idea that tinnitus is very clearly heard but is never found. And so when a patient tries to analyze their tinnitus, tries to figure out what it is, the only thing they can do is listen to it. I can't tell you how many patients I've had who have been looking for that damn cricket in the basement for the last 35 years, right? Because it's such a realistic sound, they're positive there's something there, and they've been looking around for it. Imagine what that does to you after a while. So you're positive you're hearing a sound. At some point, you become equally positive that there's no sound there. So that's going to influence the way a person is going to try to manage the effects of that sound. So now let's take that same schema here and let's put tinnitus in instead of an external sound. We know that human beings, just like all living mammals, have ongoing spontaneous neural activity in the auditory pathway. Let's recognize that damage in the periphery may trigger some compensatory changes in the central pathway. You can think of it as amplification. You can think of it as disinhibition. The effect will be the same. And now, what this does is produce an awareness of a sound that ultimately the individual realizes is not in the environment. That's going to produce a variety of negative emotions and will have the potential to increase arousal. And that's going to be an individual who will not habituate to their tinnitus because of the way that they're processing it. So if we bring this back in again, we want to recognize how important it is to help that patient manage their evaluation to the tinnitus. We're not really even in most cases talking about shutting off the sound. We're talking about improving the response to the tinnitus sound. Why is this important in patients with mental health conditions or psychological comorbid conditions? Because they seem to be more bothered by tinnitus than the patients who have tinnitus without anything else going on. Again, this is just something from our clinic, and you see the much greater rate of complaints among patients who have post-traumatic stress disorder along with their tinnitus. So how can we intervene? How can we manage? What can we do? Well, obviously I'm going to talk about drugs in just a few minutes. But there are a lot of other things that we have to do, and as you'll recognize, most of them are the same kinds of instruments that would be employed or tools that would be employed by individuals working with mental health patients. Another thing to consider is that it is very often the case that tinnitus onset or exacerbation is related to something that has nothing to do with hearing. So these are results from a little study that was done many years ago where 100 consecutive patients going into a tinnitus clinic were asked, among other things, why are you here today? What made it so bad that you had to come in today? And here's what they answered. And you would think they would be saying stuff about their ears. But the only 26 out of 100 mention anything to do with the ears, and I'm even being generous there. I'm giving the 8 that said they'd had surgery, I'm even putting that in with the ears too, because I figured they were given antibiotics, right, which could have been ototoxic. But look what's up here. Things like depression and anxiety, bereavement. Have many patients who, when you ask them, yeah, your tinnitus got bad a year ago, did something happen to you in personal life a year ago? Yeah, well, I lost my spouse. I had some personal loss. So even bereavement can trigger tinnitus, not to mention negative counseling. Negative counseling would be the instance where a patient goes to a physician and says, I've got this tinnitus, it's really bothering me, and the physician says, well, there's nothing I can do about it. Maybe we'll rule out a brain tumor. So now that patient is convinced they have a brain tumor, and they focus on their tinnitus more because they figure it's a terminal illness. Domestic problems, work problems, all kinds of things contribute to tinnitus, things that have nothing to do with hearing. So what we want to recognize is that we're going to help the people control the things they can control, and that will be what they think about stuff. If we can do that, perhaps we negate some of those negative associations, some of those thoughts, and in doing so modify an emotional response. All right, let's use some real examples again. These are complaints that we hear from our patients with respect to their hearing, their sanity sometimes. Patients are always worried about whether they're going to be able to sleep well again, whether they're going to be able to communicate well. And we can modify those things by counseling them, by giving them hearing aids, by giving them bedside noise generators that can help them sleep. And when we do that, we are very often able to help that patient modify the way they are thinking about the tinnitus. So now let's bring it back to what I was supposed to do today, which is to talk a little bit about how psychotropic drugs have been shown to, in some cases, benefit patients with tinnitus, but in the vast majority of cases, not produce much of a difference. The first attempt to use one of these medications, in this case it was Xanax, the first kind of formal study, and it wasn't particularly well controlled, but it was written up anyway, was motivated by the observation that some clinicians had that when patients took their sleeping pills or they took their Xanax, they said their tinnitus was a little bit less bothersome as a result of that. And so this guy Brummett in Oregon decided to do a very small trial just to see what would happen. And so he had 10 patients, and he gave them 0.5 milligram twice a day of Xanax. And he had planned on increasing the dosage as time went on just to see what might happen. But after the first week, he realized that was not something he was going to need to do. Sleep, as you might recall from one of the earlier figures, is one of the major problems patients with tinnitus have. Xanax helps you sleep. A lot of the patients, or all of the patients who had reported sleep problems, after 1 week were not having problems going to sleep anymore. The problem is a couple of them also were sleepy during the daytime because of the drug. And this happened even though the tinnitus sound in that first week hadn't changed. So it wasn't the sound that seemed to be bothering the patients as much as whatever it was that sound was kind of making them think, or making them kind of how they were responding to it emotionally, because the sound was still there. But the Xanax helped them sleep. After 2 weeks, half the patients said that their tinnitus seemed to be easing off somewhat. A couple other patients said that there was a change, but not quite as pronounced. But again, the idea was that with a little bit more use of the Xanax, these individuals seemed to notice a change in the tinnitus sound as well. I don't care whether the sound got lower or not. All I would care about is, were they able to function at a higher level, and were they at a place where the tinnitus was not as bothersome to them? That small study motivated a larger one, and we saw the same kinds of things. And the reason I wanted to mention these two studies is because pretty much every drug trial for tinnitus ends up this way, where you see tinnitus intrusiveness in some patients is substantially reduced, but never enough patients so that it outperforms placebo. So what we have to do is figure out which drugs are going to work for which patients. So we've got to do a better job of identifying patient subgroups, because if we do, then we might actually have something a little bit more tangible to provide. The problem is it's just not going to work for everybody. We want to recognize then also that a variety of different auditory type disorders have been used in drug trials, but the variability of the tinnitus patient group makes it so that it's going to be very difficult to find one size that fits all. Lidocaine was actually one of the first drugs that was used for tinnitus relief. As a nerve blocker, it seemed to offer some promise. There are some physicians who have done lidocaine injections around the promontory of the cochlea, deep in the ear canal near the eardrum. And lidocaine has been shown pretty successfully to ameliorate tinnitus, the sound itself, but only for about half an hour, because lidocaine gets flushed out of the body pretty quickly. But that's something that, in some cases, patients who are at their wits' end will be actually given a shot of lidocaine to at least get them some relief for a little while. With respect to the psychotropic meds, again, I don't really care if it's changing the sound or the response to the sound, as long as that patient's evaluation of what's happening is now more accurate and more benign. That's the main thing. I'm going to go through very briefly at the end these American Academy of Otolaryngology practice guidelines that are available online if you want to look at them. And because of the heterogeneity of the tinnitus patient group, there is no way to know a priori whether a drug's going to help or not, and so they're actually recommending against the use of psychotropic drugs just for tinnitus. There's no harm in using them the way they would normally be used, but we're just not going to give them to patients just for their tinnitus. Tricyclics have been looked at for a while. These are the ones that are reported in some tinnitus studies from over the years. And again, anything that reduces arousal should be of benefit to patients who have tinnitus. I probably don't need to tell you all about the side effects of those. SSRIs are used as the frontline treatment for PTSD now, and we've seen some of positive effects on tinnitus as well. These are the ones that are appearing in the tinnitus papers. Paroxetine is one I'm going to mention in just a little while. It's the only SSRI trial that passed muster, if you will, to appear in a Cochrane review. So I'll mention that one in just a little while. But again, we see the same kinds of drugs that we would see for individuals with post-traumatic stress disorder being tested on patients with tinnitus. And again, I don't think you need to be reminded of the side effects of those. Other antidepressants have been used over the years as well. Again, here, trazodone is one that seems to have gotten a lot of attention. The ones that seem to be used the most, although the trials have not been particularly well controlled, involve the benzodiazepines. So there was that Xanax trial that we saw at first. Because these reduce arousal, because these are anti-anxiety agents, we would expect them to provide some benefit. One of the problems with benzodiazepines, of course, is withdrawal. I'm sure you're all aware of the Ashton Manual, which gets given to a lot of patients with tinnitus who were on benzodiazepines for prolonged amounts of time as a way to help them withdraw from that. And again, I think you probably already know the side effects that would be involved there. A couple others. Propranolol is one that I've always been kind of interested in. This has been shown in some cases to really provide a lot of relief for patients with PTSD. It does seem to have a very calming, stabilizing influence on individuals. It's actually outlawed on the PGA Tour because it reduces jitter, like motor jitter. It's also banned in the Olympics. The biathletes were the ones who were using it, the ones who had to cross-country ski and then shoot. So you cross-country ski for a couple of kilometers, you get all worked up like that, and then you got to do some shooting, and this would help calm the individuals when they had to do that shooting without necessarily affecting their stamina on the race course. It's been, like I said, used for post-traumatic stress disorder with some positive effects, but never really looked at for tinnitus. Antispasmodic agents and anti-epileptic agents also seem to work sometimes for patients with tinnitus, and this seems to be related to forms of tinnitus that neurally really resemble burst-like, almost epileptic-like, seizure-like activity. So in some individuals, anti-epileptic meds, anti-seizure meds can actually provide benefit for tinnitus. I mentioned that Cochrane review. It's been redone a couple of times. The 2012 version is the newest one that I know about. There were, over the years, 147 studies looked at, and only 6 met the criteria for the review in the 2012 version. In those 6 studies, there were 610 total patients. You see the drugs that were employed. Again, we see some patients responding very well. We see most patients noticing some change, but not much. But in no cases does the drug outperform placebo. I take that not so much as a shortcoming of a drug, but as a endorsement of placebos. And maybe that's not the kind of thing that you ought to be saying, but we know that especially with patients who have tinnitus, the placebo effect can be pretty strong. It can be quite pronounced. Should we not use that? He asked rhetorically to the Psych Grand Rounds, people who know much more about this kind of thing than I do. I mean, I don't know. To me, anything that makes a difference is worth at least looking at. The durability, of course, was going to be questioned, but the durability of the other drugs is going to be questioned too, right? So again, just something to kind of keep in mind. That practice guideline I mentioned before, there are 12 or 13 different sort of either assessment or interventions mentioned there, and I wanted to point out 3 of them. So Tunkel et al. Were the ones who came up with this AAO, the American Academy of Otolaryngology Practice Guideline, and they have recommendations for different interventions, among them CBT and drug therapy and dietary supplements. And they're recommending for tinnitus patients cognitive behavioral therapy much more so than they would be recommending just about anything else. The evidence base for CBT in tinnitus clinical trials is stronger than for any drug or any other intervention. So that alone, I think, highlights this very powerful interaction between psychological status, mental health status, and tinnitus. Drugs are not recommended, so the practice guideline is recommending against the use of drugs for tinnitus. That individual may be taking drugs for other reasons. They might actually get some benefits from that, but nobody's prescribing psychotropic drugs just for tinnitus. That organization is recommending against that use of those drugs. Same level of recommending against that they have for dietary supplements, like ginkgo, and zinc, and melatonin, and other things like that. Ginkgo has been shown in some studies to work pretty well, not as well as, it can't outperform placebo, but again, ginkgo has been shown in a lot of ways to be very beneficial. More on that in just a moment. I'm just going to wrap things up now. Again, I still can't use this thing again. These are the main classes of drugs that have been used, along with the putative reasons for their success or failure. The overarching issue is our need to be able to identify patients for whom these interventions have the highest probability of success. Other compounds have been used and recommended over the years. The ones that seem to improve blood flow, specifically cortically and in the central nervous system, seem to be the supplements or the compounds with the greatest promise or the greatest positive effects. Just like a lot of other interventions. The clinical trials web has a lot of information on tinnitus trials that are currently ongoing. I checked yesterday. There are 192 ongoing with 31 different drugs as well as CBT and a variety of other interventions. What I hope I've been able to convey is the sort of the many-faceted the element of a very diverse set of elements associated with tinnitus that can combine or work in isolation to make the tinnitus experience very difficult for people to manage. That highlights the need for interdisciplinary, interprofessional care for these folks. I do run a tinnitus group session when I have an opportunity to at the Johnson City Community Health Center. I try to bring in pharmacy students and psych students and just to try to give as the patients views from as many different professionals as possible in order to get their questions answered. So, again, thanks for your attention. It would be great if we could find a drug that's going to work for everybody. I doubt that's going to happen, but I think the ball is in our court to let you know which patients we think will be most amenable to that kind of treatment. Thanks a lot. Questions? Yeah?
What I had was, I don't know if you know the approximate dosages that they may have used. Some of the medications, like particularly amitriptyline, the tricyclics, or the trazodone, because certainly tiny doses of trazodone for sleep can help, and then that may take some anxiolytic benefit to extending over, or if used during the day. So that would certainly make sense in terms of more globally helping. Things like, the amitriptyline, I'd be more concerned with the cardiac implications. So I was just kind of curious as to...
Yeah, and I think different studies use different dosages, and I'd have to look those up because that's not that I pay a lot of attention to. I'm kind of more interested in what agent is being used and what's the target, what's the result.
How long what was the longest duration of follow-up on any of these studies to know if it placebo, either for whatever reason it might have stuck?
Some of them go out about 6 months, right? It's rare to see one go longer than 6 months, and a lot of times the patient, whatever positive effect there was, is attenuated over time, right? Again, I think the reason that's occurring and the reason that we have to have the sort of interprofessional care for these folks is because if the patient doesn't get the kind of counseling that actually really compels them or allows them to reevaluate what the tinnitus is, then changes in the sound itself may not be as substantial as you'd like them to be, right? Any other questions?
Really enjoyed your talk. Thank you.
Thank you.
It seems to me that one of the interesting things that you said, you had the box called subcortical areas,
Sure.
which I'm very interested in. And I think that one of the things that I always think about whenever you have interrelated conditions like PTSD and tinnitus, for instance, is the possibility that brain-derived neurotrophic factor, which is almost certainly in deficiency in PTSD much of the time, could be seen as a neuroregulator for the circuitry of subcortical regions. So, for instance, in the prefrontal cortex, medial orbital prefrontal cortex, basically the value-added area of the brain, the decision about what is valued. The amygdala, fear threat, it has direct connections, hypothalamus, prefrontal cortex, superior temporal sulcus, and the thalamus. And there's this idea in neurology that basically these reverberating circuits are what cause consciousness essentially to exist. And that if you have these reverberating circuits, there's a reafferentation modulated, effectively or not, by the appropriate amount of BDNF in the system, especially in subcortical regions. In PTSD, that, for instance, it's thought that the lack of BDNF may allow the amygdala to be overactive.
Right. Without the regulatory input from the prefrontal cortex as well.
Or somehow disturbing the circuitry in such a way. What I was going to point out is that actually one of the ways to begin to look at subgroups might be using things like fMRI to try and decide which groups of patients have regions of interest that have lower level activity or appear to be poorly modulated.
Right.
And the reason that we may have a hard time defining subgroups is because right now we're kind of looking at them psychologically as subgroups, when in fact they may be neurologically definable. We just don't have the sensitivity and equipment to define.
Right, right. I think that's a very good point, and see, to me, the PTSD patient group is really the most compelling, because there are these targets for imaging studies that show these tangible changes over time, and I think we can do a better job of identifying the subgroups using techniques like that. But I think there are going to be these behavioral sort of clusters of behaviors that might sort of clue us in. Right now, one of the things that's really interesting are some neuromodulation studies where they're actually targeting where to put electrodes and sort of predicting how successful they'll be based on transcranial magnetic stimulation. So they're using neuronavigation to determine where the action center is going to be that they're going to need to target with some other kind of electrical stimulation, like a form of neuromodulation. So I'm going to use MRI to identify where in the I think I need to direct that neuromodulatory signal, and then I'm going to guide that electrode using those findings. So I think that kind of thing is going on. I don't know that that's going to help us identify subgroups, but certainly they're trying to identify the subgroup that would be most likely to benefit from that kind of invasive approach. And there are some positive results coming out of that, but those are individuals who are, as you would expect, profoundly disturbed going on.
All right. If there are no other questions, thank you for coming, and please make sure to turn in your papers on the way out.